All right, so we are your presenters. My name's Amber. I'm an intern at WSCADV. I'm getting my master's in social work at the University of Washington. So I'm a reproductive justice and policy intern here at WSCADV. My experience and why I'm talking to you about birth control is because I, before grad school, was a sex educator, and I'm still continuing that work, mostly through Planned Parenthood in Nebraska and Planned Parenthood at the Great Northwest and Hawaiian Islands. And it's just a topic that I've become a resource for folks about, so I try to stay as up to date as possible on birth control methods. Lee, would you like to introduce yourself?
Good morning, good early afternoon to everyone. I'm so glad it's sunny here in Seattle. Happy to be with all of you. Looks like we've got about 70 people joining us. Excellent. So my focus at the Coalition for the past few years has been on shepherding this conversation around reproductive justice and finding ways to make that come alive for survivors and their families. So we've been, on building partnerships, supporting partnerships really between home visitors and domestic violence advocacy programs, and working on ways to make it easier for people who might be experiencing reproductive and sexual coercion to have access to greater choice. If you know about our efforts to any advocacy program that wants emergency contraception on site can have it. And so we're really happy to continue this conversation and get everyone comfortable talking about birth control. You don't have to be experts, but it's good to just know those critical questions and to think about how this is tied to our work around reproductive justice. Thank you.
So our agenda for today, we'll briefly talk about our new reproductive justice framework that informs the way we speak about birth control and reproductive and sexual coercion. I will go over the birth control methods, and then Lee will talk us through reproductive and sexual coercion and our framework for survivor approach. And last, we'll finish with Washington State healthcare coverage and resources. So here at WSCADV, we have recently developed new reproductive justice messaging that I will read out loud for you. This is just part of it. Decisions around birth control, when to get pregnant, and how to parent are complicated, even in the best of circumstances. Everyone should be free to make decisions about their body and their family and experience sexuality without violence, coercion, and external control. We are working towards reproductive justice by ensuring that all people have the right to not have children, to have children, and to parent those children in safe environments. Okay, we will now talk about birth control methods. Birth control is a big topic, and I want to be clear that I will not be able to cover all of it today. Today, I will talk about hormonal and non-hormonal IUDs, the implant, the shot, the pill, the patch, the ring, and emergency contraception. I will not be discussing condoms, calendar methods, fertility awareness, or LAM, but if you would like me to direct you toward reliable resources about any methods that are not mentioned today, please contact me. I know there are some medical professionals on this webinar, and I just want to be transparent that I am not a licensed medical professional. My experience is teaching birth control to young people, college-age students, young adults. So I hope that everyone finds this language accessible and not heavy with medical terms. The purpose of this webinar is not so much for you to understand all of the medicine, the science behind birth control, because that information is widely available online if you're curious. We want you to have the basics of the options, especially as they apply to people who are experiencing reproductive and sexual coercion. Okay, the first method that we will talk about is the copper or non-hormonal IUD. The only brand that exists in the US is Paragard. And this will be the format for each method that I'm going to talk about. So I'll have the name at the top, the amount of time that it works for, the mechanism, and then some survivor considerations. And what survivor considerations mean is if someone is experiencing reproductive or sexual coercion, these are some things to take into consideration. So the copper IUD can last up to 10 to 12 years. And the reason I say up to is because it does not have to stay in for 10 to 12 years. If someone decides that they would like to become pregnant or that this method is not working well for them, they can have it removed anytime before the 10 to 12 years. It is currently FDA approved for 10 years, but research has shown that it is actually working up to 12 years, which is why there is a range of 10 to 12. And if you can see my cursor, which I hope you can, I'll show you the mechanism or how this is inserted and removed just by pointing my mouse onto certain parts of anatomy. So it is inserted through the vagina. It goes up through the vagina, past the cervix, and then it stays in the uterus where it expands into this T shape. The way it works is that copper, which you can see is on the stem and sometimes on each side of the IUD, creates an inflammatory reaction that is toxic to sperm and eggs, but is safe for the person who has the IUD in their uterus. And you can see here that there are strings that are coming out of the cervix. The reason those strings are there is because this method, while it can stay in for up to 10 to 12 years, they recommend going in annually to make sure that it's still in place. So those strings help medical providers know that the IUD is still in place. So if the strings are hanging much lower, for example, that could be a sign that something is wrong. Something to note before I dive into survivor considerations, when I talk to young people in particular about IUDs and we talk about the strings, something that becomes confusing is the comparison to tampon strings. So people are afraid that this means that the strings actually hang out of the vagina like a tampon. I just want to be clear that that is not the case, that it comes from, the strings come from the cervix, so they are still inside the body. The strings could be felt potentially by a partner, like with their fingers or with their penis. So if people are concerned about that because it's physically uncomfortable for their partner or because they're worried that their partner will know that they have an IUD inserted, what a medical provider can do is cut the strings so they are less detectable. They can cut them off like where the cervix ends, or I hear now that they can cut the string off entirely. And this would just mean being your communication with your healthcare provider about your concern so they know alternative ways to check that the IUD is in place. But it is not rare for people to ask for the strings to be shortened because they're worried about detection or because it's uncomfortable for their partner. So survivor considerations, this is a non-hormonal method. So if someone's periods are being monitored, this method does not prevent periods from happening. Something to know as a side effect is that it can cause, sorry, I'll move my mouse, it's just going all over the place. It can cause some spotting between periods sometime. It can also cause heavier or longer periods or more cramping during periods. But it does not make them go away like the other methods that I'll get to next. This method is also safe to use while breastfeeding. I know that's a question that some people had during registration. And it can also be used as emergency contraception, which I will get to when we talk about emergency contraception. The next method that I'd like to talk to you about are hormonal IUDs. So these look very similar to the method I just showed you, which was a non-hormonal copper IUD. These ones that I will be talking about do have hormones, but they are inserted the same way. So they're also going up through the vagina into the cervix, and it lives in the uterus. And same story with the strings. These strings come out of the cervix, not the vagina, and they can be cut shorter or completely. So the last IUD had one brand, it was Paragard, where the hormonal IUD actually has 4 right now. So if you hear names, Mirena, Kylena, Skyla, or Liletta, those are the hormonal IUDs. And the time that they last is up to 3 to 7 years. And it's not because each one has a range, it's because each one has a specific time. But I just showing, like Mirena, I believe is 7 years, Kylena is 5, Skyla and Liletta, I'm forgetting off the top of my head, but each one has a specific year that it's currently FDA approved for, not a range. And what's also important to know, you don't have to know the difference between Mirena, Kylena, Skyla, and Liletta. I guess what's most important to think about is that there is a difference. Historically, IUDs were for people who have given vaginal birth, and that was the Mirena. It's larger in size than the other ones. The other ones were then created because IUDs, people wanted IUDs available to people who are younger or who have not given vaginal birth before. So, for example, Kylena and Skyla are smaller and they have less hormones. So you don't need to know the specifics about that, but if someone says, I haven't had kids, an IUD wouldn't work for me, know that that is no longer the case. So same mechanism that I told you, however, this does have a hormone in it. That hormone is called progestin, and it works by keeping ovaries from releasing eggs, which is called ovulation. It prevents ovulation. It thickens cervical mucus, which can block sperm from entering through the cervix, and it thins the lining of the uterus, which makes implantation less likely. Those are the three mechanisms that progestin birth control uses. Some survivor considerations are that periods may go away entirely or happen less frequently, which for some people is wonderful and they appreciate that. For others whose periods are being monitored, know that their periods may stop, which is safe for the body. Also, irregular bleeding, also known as spotting, may occur after insertion. That could be, 2 weeks after, it could be a few months after. And again, the strings can be cut shorter or completely by the provider. The next method is the birth control implant. The current brand name in the US is Nexplanon. This is FDA approved up to 4 years, but other research, newer research is saying that can actually last up to 5 years. And again, it says up to, just like the last methods, because it doesn't have to be in for 4 years. If someone changes their mind, it's not working for them, they can get it removed before that. This works by a medical provider inserting the implant, which, as you can see on this top image, is 1.6 inches long. The size that it's compared to often is of a matchstick. Oh, sorry, I see a question in the chat box from Tiffany. Tiffany's asking, is a copper IUD appropriate for someone who has not had a child? I have not heard that it is not appropriate. So as far as I know, the copper IUD is appropriate for someone who has not had a child, but I'm happy to find some certain information on that for you, Tiffany. Thank you for asking. So like I said, people usually compare that implant to a matchstick, but I would argue that it's actually even smaller. And it's inserted into the inside of the upper arm. So this photo here, you can kind of see it under that person's skin. And this is the exact same hormone that I was sharing about for the hormonal IUD. The way that it works is progestin is keeping the ovaries from releasing eggs. It thickens cervical mucus and thins the lining of the uterus. This time, though, that hormone is delivered through a mechanism that is now in the arm. Because it's the same hormone as the last thing that we talked about, the periods, it's the same case for periods, so they may go away or lessen, and spotting or irregular bleeding could occur after insertion. Additionally, with this method, it's important to know that bruising may occur after insertion, bruising happening at the site of insertion. For some people, there's no bruising. For some, there is a lot of bruising, and there may not be a way to know if that will happen to someone or not. Even after this method is inserted, though, it sits under the surface of the skin. So it may be felt by a partner if it's because of where it's placed. So that's also something to consider. It's not necessarily visible. It's visible here because they're pressing against the skin, but if someone happens to touch someone in that particular spot, you can feel it under the skin. Because of time, I'm going to hold questions until the end of this part, because I do have a question slide that I forgot about, but please keep them coming, and I promise I will get to them toward the end of this. Okay, and then another progestin-only method is the shot, or Depo-Provera. It's administered every 3 months through an injection given by a healthcare provider. Same story with this hormone. Progestin prevents ovulation, thickens cervical mucus, and thins the lining of the uterus. Some survivor considerations for this method are that it's easily hidden, it's a shot, periods may go away or lessen, but it does require going to a clinic for each shot. Okay, I know this slide's a little overwhelming. I promise I'll break it down for you. I'm going to tell you now about what are commonly known as the combined hormones method. So far we've talked about the copper IUD, which is non-hormonal. We've talked about hormonal IUDs, the implant, and the shot, which all have one hormone called progestin. And now I'll talk about the pill, the ring, and the patch, which have 2 hormones. So the first one, the pill, most people know about this. It is taken daily. The NuvaRing is inserted into the vagina every week. You take it out and put a new one in for 3 weeks. And then the patch can stay on up to 3 weeks or a month. It can't stay on for a month. I apologize, I just said that. But it's considered a month-long birth control method. I'll explain that a little more. Each of these methods has 2 hormones. They have estrogen and progestin that are delivered through each method for 3 weeks, and then a period happens the 4th week because you are no longer using that method. So you take the birth control pill every day for 3 weeks, have a period the 4th week. The NuvaRing, you're swapping a new one out for 3 weeks. You don't have one in the 4th week, you have a period. With the birth control patch, you keep it on your skin for 3 weeks, you take it off the 4th week, have a period. If someone doesn't want to have a period, it is safe to not have one with combined hormone pills and the ring. You just want to be able to plan that with your provider. With the patch, blood clots become a risk, so that's something, again, you'd want to talk to your provider about. You wouldn't just want to do the methods without talking to a provider and not ever take a break from it for that period for the 4th week. It's something you would want to plan with a medical provider. Some benefits to the combined hormone method is that if people find comfort in knowing their period every month, like that it's coming every month, which is the case for a lot of people that I talk to, it's important for them to have a period every month for peace of mind. These are great methods because they will have a period the 4th week, every week. It can also help with period pain, endometriosis, and many more things. Some people take these methods not even for birth control, but because it has other helpful effects, and that includes the other methods that we've talked about so far. Some survivor considerations. These methods are just as effective as the methods we've talked about before, but when you see it on paper, it may look like they are less effective. The reason that looks that way is because there's more room for human error. These methods do require more maintenance. So it's not that they are less effective when used correctly, it's that they become less effective because there's more room for error. Some other considerations about each of these is that a pill may be more difficult to hide. The NuvaRing is actually heat activated. So providers say that you should keep this in your refrigerator until you use it because the hormones are released through heat or body heat. That's how it's activated once it's inserted into the vagina. This method also requires someone to be very comfortable inserting and removing a method from their own vagina. It may be felt by a partner. So if that is a concern, that's something you'd want to talk to a provider about because it sits at the back of the vagina. And then the patch, unfortunately, it only comes in one color. So it's like a yellowish peach color. It can really stand out against even light skin that doesn't match that tone, but even more so against darker skin. That's good to know. So someone had shared that the NuvaRing may last up to 3 weeks instead of weekly, which would definitely be more convenient for people. Okay, I do want to show you a resource. I'm going to close out of the slideshow and show you a website. Okay, you should be able to see on my screen a website called Bedsider. And Laurel and Lee, if you cannot see that, please let me know. And I'll just walk you through it, my favorite part of this website. So if you click on birth control methods, so what they do is show you methods, including methods that I said I wasn't able to talk about today. So they have fertility awareness, they have diaphragms, caps, sponge, spermicide, withdrawal. They also have sterilization, and then they have the methods that I've talked about as well. You can roll over it and find more information. And up here it has some categories. This is how they categorize them, like most effective. So if I click on that, it gets rid of some of the methods and then keeps the most effective ones up, like sterilization, implant, or IUD. The ones that I want to direct your attention to are the ones that people have asked about in the registration. And those are hormone-free and easy to hide methods. Now keep in mind this website was created for young people. So easy to hide may mean easy to hide from parents or caregivers, not necessarily always a partner who may be monitoring the reproductive or sexual health. At the bottom though, this is my favorite feature, is if you go to view a side-by-side comparison and then go to build your own, you can just pick up to three methods to compare. So just for the heck of it, I'm gonna compare the hormonal IUD, the non-hormonal IUD, and the implant. So if you look along here on the left side, it compares based on effectiveness, side effects. Do Me Now is like the spontaneity and pleasure category. STI prevention, hormone-free, easy to hide. I won't read all of them, but you can just see that they compare based on really what a lot of people have concerns about and some of the concerns that you express in registration, especially safe for new moms. This is not heavily medical. This is meant to be a resource for people who are considering it. They do have a provider's website, and I know providers that have used this, but I don't know what any limitations are for accessing that. But this is just nice to walk clients through so they can compare. Someone had also asked about if there's a certain amount of weight where the level of hormones would no longer make the implant effective. I am not sure, but thank you for asking that. Our contact information will be at the end if you'd like me to answer that at a later time. Okay, I am gonna go on. I'm sorry if things got lost in the chat, but I wanna be able to get to emergency contraception. So I'm going to start with reasons that people may want to use emergency contraception. And those are that the condom has broken or slipped off, they miscalculated days, someone did not withdraw or pull out in time, they're not using any type of birth control, a diaphragm or cap slipped, they got the depot shot late, forgot to take their birth control, maybe access, money, health insurance is an issue, or sexual assault.
Okay, so the question is, can you talk about depot shot for patient self-administration at home during social distancing?
Okay. As far as I know, the U.S. does not have self-administered depot for people at home, but I'm not sure. But that is definitely an access issue right now during social distancing, of whether or not people can even get to a clinic. Lee will talk about Washington access, and for folks that are curious about where people can get that, but I do know that clinics are still doing, like some clinics are still doing this. You just want to express that, or maybe this means the discussion of another method, which I know would not be preferred. So I'm not sure about self-administered depot right now. It's not something I've heard a lot about, but if anyone else has, please feel free to write that information in the chat box.
And I have a couple
Oh, great.
more questions.
Someone's saying,
oh yeah, go ahead.
oh, okay. Michelle just said that some clinics are teaching self-administration of injections, including depot, which is great. Thank you, Michelle. Go ahead, Lee.
So that would mean check with your local community clinic to see if that's happening.
Absolutely.
Right? Okay.
Yes.
So I have a couple of questions that you may or may not be able to answer. These are great questions, so we'll have them in the chat box, y'all. We can follow up. So one is it normal to stop the birth control pill and not get your period for 4 or 5 months?
Yeah. So when you stop taking a birth control method, your body will go back to what's normal for you. So if it was normal for someone to not get their period for 4 or 5 months when they were not on birth control, that's why the word normal is hard to answer. But if that's something someone is concerned about, there could be something underlying there that they should talk about with their medical provider.
And then I have one more question. It seems a little more technical. We might have to get back to this, but I'm going to read it to you anyway.
Okay.
So our participant would be interested to hear more about the mechanism of action for the Paragard. Is it preventing implementation of a fertilized eye, which to some may be considered a form of pregnancy termination?
Yeah, so that's a values question. If someone views prevention of implantation as pregnancy termination, and that goes against their values, that is okay for them to not want to use it for that reason. But also understand that it's the progestin is preventing an egg, is actually preventing ovulation. So that prevention of implantation is more of a safeguard rather than it's not guaranteeing that an egg's being released every time when you're on that method, and then it's just like not letting it implant. The egg's actually not being released when you're on this method. So I don't know if I explained that really well, but if that becomes something that conflicts with someone's values, there are definitely other options. And Yvonne asked a question. I had more than one client tell me that Plan B is easier to get. What are the consequences for taking Plan B consistently? Thank you for asking that. I'm about to get to it, Yvonne. All right, so let's dive into emergency contraception. I'm going to go over this quickly because we've already talked about the copper IUD, but it is the most effective form of emergency contraception. Now, there are access issues with this. It means you have to be able to get this placed by a provider within 120 hours or 5 days after unprotected sex. For some people, that is very easy. For some, it is not. What you'd want to do when you're making an appointment is make sure you say that you want the copper IUD because you have had unprotected sex. They will ask you when and see if it's a good fit for you. The benefit of this is it can stay in for up to 10 to 12 years, whether you wanted it for emergency contraception or not. So it could be a continued method of birth control, and it's just as effective regardless of body weight. And the reason they say 5 days is because sperm can live in the body for up to 125 hours or 5 days, which is why you have up to 5 days to have it placed. Now, let's dive into the pill. I know this is so much written information, but I wanted you to have all of it. So there are two options when it comes to morning after pills for emergency contraception. The first is a pill with olipristal acetate, and the only one that exists right now in the US is called Ella. You do need a prescription for Ella, but you can get You can get a fast consultation and next day delivery online. It is the most effective type of morning after pill, and you can take it up to, just like the IUD that we just talked about, you can take it up to 120 hours or 5 days after unprotected sex, and it works just as well on day 5 as it does on day 1. As far as why, I am not sure. If you're taking emergency soft contraception because, maybe someone made a mistake with their hormonal birth control, they do recommend using Plan B or the copper IUD instead of Ella if that has been the case. And because folks asked about breastfeeding, I have found that if breastfeeding, you can pump and throw away your milk for 24 hours after taking Ella. The next method is a pill with levonorgestrel, which are the more common ones that we see over the counter or in pharmacies. They have a lot of different brand names that include Plan B One Step, Take Action, My Way, After Pill, and more. These types of morning after pills work best when you take them within 72 hours or 3 days after unprotected sex. But you can take them up to 5 days after. They just may be less effective. But with this one, the sooner you take it, the better. Just because it's the morning after pill doesn't mean you should wait or need to wait until the morning after. You can take it as soon as one of those accidents that we had talked about happens. And to the question that was asked about folks, I've read that this does not affect breast milk. If you have found anything different, please let me know, because this is something people were definitely curious about. Taking the morning after pill whenever you need to will not hurt you, but it's not a good idea to rely on the morning after pill as your regular go-to method of birth control. And that's because it doesn't prevent pregnancy as well as other forms of birth control, like the ones we've previously talked about. Also, taking the morning after pill over and over again it's actually more expensive. Some places you can find this for free, but over the counter it's expensive. It can be inconvenient and it could be stressful, more stressful than being on a regular method of birth control. The side effects are temporary and harmless, but they can be annoying, like bleeding between periods or nausea. So if someone is telling you that they are relying on emergency contraception because it is more accessible to them, know that it won't necessarily hurt their body, but it's just not recommended because that can add up cost-wise. Also to know that you're reacting that way every time, like kind of that panic that can be happening whenever you are needing to access it. So there are some methods that we've talked about that contribute more to peace of mind, and we'll be able to talk to you more about access if someone is worried about that access. Okay, and how does emergency contraception actually work? And this is more about the pills I just shared about, not the copper IUD. Like I said, pregnancy does not happen right after someone has sex. That's why it's possible to prevent pregnancy a few days after, or even up to 5. It's all about timing. Sperm can live inside the body for up to 5 to 6 days after sex, just waiting for an egg to show up. If someone ovulates during that time, the sperm can meet up with an egg and cause pregnancy. Morning after pills work by temporarily stopping the ovary from releasing an egg. It's kind of like pushing the emergency brake on ovulation. Where someone is at in their menstrual cycle and how soon they can take morning after pills can affect how well they prevent pregnancy. Morning after pills will not work if somebody's body has already started ovulating. That is why timing is important. However, most people don't know exactly when they ovulate, so it's best to use emergency contraception as soon as possible, no matter where someone is in their menstrual cycle or whether or not they think they're about to ovulate. I want to be clear that the morning after pill is not the same thing as the abortion pill. The morning after pill does not cause an abortion. It will not work if someone is already pregnant, and it will not harm an existing pregnancy. Emergency contraception is birth control, not abortion, and it does not end a pregnancy. It prevents one. I want to show you my favorite resource. I just love Bedsider. I swear I'm not getting paid by them to promote them, but they're so accessible. So they have this handout. I'm not going to go through all of it with all of you, but you can order these from their website, and it's just this stack that you can, rip one off and give it to your clients. It is like an 8.5 by 11 page. It is quite colorful, or you can direct people to their app or the website if they cannot have a piece of paper. But it just compares the 3 methods that we just talked about: the Paragard copper IUD, Ella, which is a prescription emergency contraception, and then Plan B, one-step, or that generic birth control. People are asking if they'll have access to the slides or if this will be recorded. Absolutely. Thank you for asking. So it compares, how well does it work? How soon do I have to use it? How do I use it? Where can I get it? It's so helpful. And someone was asking a question about weight restrictions. Know that Ella and Plan B do have some weight restrictions. So Ella is less effective if you're over 195 pounds. And Plan B, the morning after pill that's sold in stores, is less effective if over 165 pounds. Have someone talk to a provider about this if they're curious. And what I say is it never hurts to take one of these to reduce your chances. What is not recommended is doubling the dose. Like, that won't make it more effective. Taking 2 Plan Bs doesn't make this twice as effective, or taking 2 Ellas does not double your chances of pregnancy prevention. So that is not recommended. I don't know why the weight restrictions are there. It is frustrating. A lot of people are not under those weights. So that is a thing that exists with emergency contraception pills.
Hey, Amber, this is Lee. Can I jump in here for a second?
Please do.
So the weight question comes up a lot, and I guess I'm really thinking about our advocates and folks coming to getting support and asking about this in particular. And so I just want to add to it that I've seen different studies talking about even different levels of weight, even with this recommendation. So I think for survivors who maybe the only emergency contraception they can get a hold of is through you, an advocate, or it's something they can order online. As Amber said, it doesn't hurt to take the emergency contraception, and it may still work because I think all of our bodies are different and have different sensitivities, despite even with these guidelines. So because it doesn't hurt, you may have access to it. I think if you're a survivor, you're concerned, it's worth, and you have access to it, it's worth giving it a try. Thank you.
Thanks, Lee. And my last slide for emergency contraception is about access. So the question is, can our DV and dual advocacy programs make over-the-counter non-prescription medication, pregnancy tests, and emergency contraception available participants and their children using our program services? The answer is yes. The good news is we can remove barriers and give people access to over-the-counter medication for themselves or their children in our programs. And that Plan B, or the one-step pill, the generic morning after pill that is non-prescription we talked about, is available without a prescription. That wasn't the case when it started. It is now non-prescription for any age and any gender. So if someone is really worried about going themselves, someone else can buy it for them. And that means you don't have to show an ID at a store, pharmacy, or online. And now I will step back and have Lee talk about reproductive and sexual coercion.
Thanks, Amber. Okay, so let's keep going. So Amber, if you would forward the next slide for me, please. Okay, so thinking about reproductive and sexual coercion, I think especially for advocates and home visitors who've been having conversations with survivors who they know are experiencing coercion and abuse in their relationships, this information, it's not new information, but what was really helpful when Futures Without Violence did this study is that it was a way for us who are doing this work to make linkages for folks to understand what's happening for folks living in coercive abusive relationships around their decisions and choices around family planning and sexuality. So it really makes sense to us. Of course, if you're living in a coercive and abusive relationship, you might have less decision-making power over what happens. And if you're having unplanned pregnancies, not necessarily not wanted, and you're having more than one, again, you may not be able to make decisions the way you want to around family planning and sexuality and access to birth control. So you can see that these things go back and forth. And this study, which was done in the early 2000s in Planned Parenthood clinics, it really helped show the link that a lot of us know from common sense, that both of these go both ways. And what was also helpful for us, especially those of us who are advocating or working with younger people who may be getting pregnant, is the way that people would talk about young folks is they would say, you know, their brains aren't fully formed, they just don't have good information, they just don't have good education. And really the research wasn't looking at the context in which people are getting pregnant. Maybe that young person didn't have support or control or access to birth control or support around birth control negotiation or support around their decisions. So for those of us doing the advocacy work or supporting families, it was a way for us to say to folks who, you know, and other systems and other providers that we have to work with is like, the reason why this person may be pregnant again so quickly is not because they don't have good information, but because they didn't have as many choices around family planning or birth control use. And so to really try to have a more dignified and respectful understanding of the circumstances around pregnancy. So that study happened in California, early 2000s, Planned Parenthood clinic, and women who coming through in the study who said they were experiencing coercive and abusive relationships also raised their hand around experiencing forms of reproductive and sexual coercion. And we'll talk about that in a minute. I want to also show at the same time another study was happening. If you go to the next slide. We had in 2010, just over a month, we had 3,000 callers who voluntarily participated in a survey with our National Domestic Violence Hotline, and their ages ranged from 13 to 55, with more people between 25 and 35. And they were talked about the ways they felt like their birth control use was undermined or the kind of pregnancy pressure that they felt in their relationship. So again, it was just more concrete evidence or data to support what many of us often knew in supporting survivors in abusive and coercive relationships. So from both of these studies, Futures Without Violence came up with this term, next slide, called reproductive and sexual coercion. So again, I always like to say it's kind of a fancy term to talk about the ways people use someone who is in a partner may maintain power and control in the relationship through reproductive health issues. So making it hard to negotiate birth control use or influencing pregnancy decisions, whether to be pregnant or not to be pregnant, and even using physical force or other very coercive threats around reproductive health. So it could be like very explicit attempts to impregnate a partner against their will. So what could that look like? In birth control sabotage, that could look like hiding birth control, destroying it, putting a hole in a condom, not withdrawing when that was the agreed upon method, pulling out vaginal rings, tearing off contraceptive patches, pulling an IUD out by a string. Ouch. Always think that's a very ouchy one to think about. Pregnancy pressure could be like, I'm going to leave you if you don't have a baby. This is why aren't you pregnant yet? or I want you to terminate this pregnancy. I don't want you to carry forward with it. Maybe hurting somebody in a way that they might have a miscarriage, or even forcing people to have an abortion if they didn't want to have an abortion. So it can get really very explicit in threats and coercive action. And, you know, this also applies for people who are in same-gendered or same-sex relationships as well. Anyone who can be pressured or have their birth control use undermined. Okay, so that's the framework of trying to of what reproductive and sexual coercion is about. And I feel like some of the folks that we're supporting, it's not like we want people to raise their hand and say they're experiencing reproductive and sexual coercion, but for those of you who are doing advocacy work and especially also home visitors, just to be listening differently when you're asking questions around birth control use, or when you're just giving information about birth control. And I see I had a question, can pregnancy pressure also include becoming pregnant to keep their partner in the relationship? I think that's absolutely true, that people have, maybe a survivor has said to you, the only time things are going well is when I am pregnant, and things seem to be better in the relationship then. So that might be a conversation that you're having over a long period of time, where you're building a trusting relationship with the survivor to figure out what else you can do to support them and to help strengthen the relationship as well. So when are you more likely to bring up birth control with a survivor? I see, Amber, that one of the categories at the top is a little covered by the ring. Do you know what it says?
Yes, sorry about that. That is the unsure response, and the percentage is 4.9%. And this is based on your answers when you registered.
So thank you, Amber. So what I see here is that most of you are bringing up birth control and talking about birth control when a concrete action is happening. So a good percentage of you are when the client brings it up, around a sexual assault, during or after pregnancy, when someone feels it's necessary, or intake or safety planning. So that totally makes sense, because on all of our work, whether we're advocates or home visitors, we're trying to follow the lead of the survivor, follow the lead of the parent. But we have one other thing we'd like to introduce into your strategies and your approach about sharing information around birth control with the families you're working with. So we have this framework that we call, it's a little small, I hope you all can see it, don't ask, just tell. Thank you. So what we're hoping, a strategy we're hoping to add to your ways of talking about birth control and just opening the door to that conversation, is that if in our conversations as advocates or home visitors, is if there's a time when you would be just offering information about many of the things that are hard, maybe more sensitive situation, like talking about how people are doing around their emotional and mental health, or just even offering resources, or saying to people, you know, we can support you through explaining to you things around the resources we have in our community, the resources we have access here. We can talk about safer planning. We can talk about court orders, if that's something you're worried about. We can talk about options or resources we know around immigration, refugee issues, status, even if you're undocumented. And we also have information about birth control and other options for birth control that are less likely to be felt by a partner. Just putting the information out there is that, like, we don't have to wait for someone to tell us their story, because most of the time when people reach out to advocates, they're not calling necessarily because they've just had unprotected sex, unless specifically around a sexual assault advocate who might be, someone might be calling about sexual assault. But most of the time people are calling us because they're worried about housing, or they're worried about something that's going on in their relationship. These are for advocates. For home visitors, you're doing a range of things. And the last thing, especially as you're building that relationship, is they're going to talk to you about unprotected sex. And for both of you, both disciplines, they're not going to be saying to you necessarily in that relationship, listen, maybe the sex is the only thing that's still good between us, or I'm doing it to help keep the peace in the home, I'm having sex. But if we put information out there that we just say as part of your general birth control pitch, or as part of your general overview about health and reproductive health, there are forms of birth control that are less likely to be felt by a partner. There are forms of birth control that don't interrupt your period. There are forms of birth control that are you don't have to remember to take every week or every day. And that's information I can provide you now or later, whenever you're ready. It's just sort of like, it is that don't ask, just tell. Put the information out there, and then people will ask you when they're ready. So for instance, when we've done some focus groups around this approach with other advocacy programs, we've had people say, when we talked to survivors about this, they said, we didn't know you we didn't even know you had information about birth control. Or I had somebody say to me who was close to my age in their 50s say, well, I'm not worried about birth control, but I'm worried that I might have an infection because my husband is not being faithful to me. Or we had other survivors say, I'm not so worried about birth control, but I want to know how to talk about it with my kid. So it just kind of opened the door to talking about sexual health, reproductive health, other kinds of issues, just putting it out there, whether you're a home visitor or you're a domestic violence or sexual assault advocate, that you can talk more generally about other forms of birth control. You don't have to remember all the details, you know where to get them, but it's just like those critical overview questions to just signal that you're a person when they're ready, if they want, that you can talk about this information. The other thing I think about is like some people have what I think of as like survival sex. I had sex so that I could get food. I had sex so I had a place to sleep. And people may be feeling really embarrassed, ashamed, not the thing they want to talk about, but it still would be helpful for them to know about emergency contraception or other forms of birth control that they can get access to. So if we just proactively say we have that information, then treating people with dignity and as the adults that they are will bring that up with us. So the other thing advocates and home visitors often ask me is like, are we offending someone if we tell them we have emergency contraception or pregnancy tests, especially people who may be seeking our help or we're connecting with who come from communities where maybe birth control is frowned on. We're not sure what people's cultural or religious beliefs are. And I think that as long as we're not telling people what to do, but we're saying we have this resource, or we have access to this resource, it's not a service, right? We have access to this resource, or we tell people where you can get this information, then people will make their own choices. And there's lots of research out there that show that people can belong to religious or cultural communities that are not supportive of birth control and still want to be in their community and make an individual choice. So for instance, I'll bring up my own community. I'm Jewish. Sometimes I do, I've certainly done advocacy in the Jewish community as a domestic violence advocate. I still support survivors in the Jewish community who reach out to me. And I can think of a story that I would like to tell you that my friend, who is a primary care physician, who is not Jewish, who said to me she was visited by an Orthodox Jewish woman who had 6 kids and wanted an IUD placed with the strings cut off. Just came in asking for that. My friend did it, and the Orthodox woman didn't come back for a follow-up appointment. And my friend is not Jewish. So this Orthodox woman stepped outside her Jewish community to get that service, to get that medical help, but didn't come back. She sent a friend, another Orthodox Jewish woman who had, I think, the same number of children, and asked for the same thing, IUD with the strings cut off. And again, didn't come back for a follow-up appointment, but got what she needed. So I asked my friend, the doctor, I said, do you think you could just add to your general overview when you talk about control, these are forms of birth control that don't interrupt your period if your period is if you don't interrupt your period, if you cut the strings off, are less likely to be felt by a partner. Just normalize it and make it part of your general conversation so you don't have to figure out who might need that information and who might not. And she said yes, she could do that. So that's just, I hope that's reassuring to know if we're not telling people what to do, we're just offering them information, people will make their own choices. Okay, so like next slide. So for advocates, and I think domestic violence, sexual assault advocates, and I also think home visitors who've been involved in safer planning, you know, these are some questions that when you've had the time to talk with a survivor that you can work into your conversation. Obviously, these were written with some of us knowing we're face to face with people. None of us are face to face with people now. But if you're having a private and confidential conversation, to be able to check in with people if they have a birth control that they like, if they have access to emergency contraception, can they put it in a safe place? Because, you know, if you're living in a coercive, abusive relationship, and even if the sex is still the thing that's good between them, she still may not have the decision-making ability around what kind of birth control is being used. There may be no birth control negotiation. And having some emergency contraception out of the packaging, hidden in your vitamin bottle, hidden somewhere else may be a good thing. And as my public health nurses tell me, as long as it's not, you know, in a blazing hot car or in the freezer, it'll last for pretty long. And again, it just kind of opens the door. You know, you can say to people, we're just thinking about all the things that you might need to be healthy, safe, and we want to make sure you don't have extra things to worry about. And people can be surprised by pregnancy or can be surprised by a sexually transmitted infection. Thinking about birth control use or access to it can help reduce someone's stress, even if they don't bring it up. So it just brings it back to that question. We're following the lead of people. We're not telling them what to do, but we're offering information. Don't ask, just tell. Now the birth control poster. So we have this online. I'm not going to do a hyperlink right now, but these are the birth control methods that can be used without a partner's knowledge. And again, they're just focused on injection, emergency contraception, implant, the copper IUD, the hormonal IUD, and in the column that says risks of detection, tell us which forms of birth control will interrupt a period, which ones won't. Again, the copper IUD, cutting off the string, is probably the less likely to be known or felt, or the stealthiest, as I call it. And we also have emergency contraception. This poster is also in Spanish when you go there. We originally wrote it for advocates and home visitors to have, but I've seen it up in bathrooms. You can fold it in 8.5 by 11. Again, it's all part of that don't ask, just tell approach. Okay, so we're moving into a little bit of healthcare for survivors and teens. So we're going to focus on healthcare coverage, thinking about teens who might need confidential information, or minors, and may or may not be living in an abusive, coercive relationship, and survivors. So let's go to the next slide. So we just want to be really clear, and we have access to the handout that's on our website. And I think that's going to also be sent to you with this, with the PowerPoint, and maybe Laurel can put that into the chat box. But in Washington State, minors do not need consent or notify anybody for birth control services, abortion services, or prenatal care services. If the minor is 14 or older, you have to be 14 or older to get that sexually transmitted disease testing and treatment, including HIV testing and treatment. So that's good news. That means adults and minors don't need to talk to anybody or get anybody's permission for birth control, abortion services, or prenatal care. We just like to emphasize this for everybody. If you're a survivor of domestic violence and you prove it, it's all self-report. You don't have to have a police report or a court order. You can enroll for health care coverage at any time. And that's for anybody in the country. That's federal law, but we also have a 2-pager, a handout that we put together that lives on our website for advocates and home visitors that just helps you understand what options are available for domestic violence survivors. So survivors can enroll separate from their partner, even if their partner already has healthcare coverage. And navigators and tribal assisters should be trained in how to do this work from healthcare authority. And a lot of advocates know that. Maybe this is new information for home visitors. I'm not sure, but we just like to remind people of that. Go to that 2-pager. It'll get your questions answered and it'll have phone numbers for you. The next one to share is these are new programs that just got going in January of this year. And they're new application forms. Okay, so some of you may have been familiar with the term Take Charge. That used to be the contraception program in our state. Now we have family planning only programs. So one thing, this has a lot of text, so we're going to try to summarize it. Both programs serve the same purpose. They're trying to fill in coverage gaps and offer confidential family planning services. So in our state, our version of state-funded Medicaid, so like thinking of it as expanded Medicaid coverage, is called Apple Health. I think most of you all are familiar for it. But we wanted to let you know, as of January 2020, undocumented folks are now eligible for both programs and a social security number is not required. So the family planning only program is a standalone family contraception family planning program. The difference from the family planning only pregnancy, it's for folks, it's a contraception program, but it's also for folks who've been pregnant, given birth, or their pregnancy has ended. What's new is that undocumented folks are now eligible for both programs. It used to be just pregnancy, but now for the family planning only. And we just wanted to make sure we're still working on getting clarity on whether applying for Apple Healthcare or Washington State Medicaid will impact the public charge status for immigrants, refugees, undocumented folks who are applying for legal status. It's unclear at this point, but we just wanted to let folks know that you don't have to. So in summary, let's just go to that you don't have to, if you're a teen who needs confidential services or a domestic violence survivor, you do not have to apply for Apple Health first to access the family only programs. So if you're a domestic violence or sexual assault advocate or a home visitor, again, working with a teen who wants confidential services, you don't have to jump through the Apple Health Care application process first. Or you're a victim of domestic violence, you don't have to jump through the Apple Healthcare application process first. So if you're calling an assister or a navigator and you say you're a victim of domestic violence and you're undocumented, you don't have to go through the Apple Healthcare process first. And that means, of course, your public charge status will not be impacted because of that. And so we're hoping that in summary, what that means is undocumented folks are eligible for both programs. Teens wanting confidential services, domestic violence survivors / victims do not have to apply for the Apple Healthcare coverage first. That would include, an undocumented person and being denied that let's remember that domestic violence survivors can always apply for healthcare at any time, even outside open enrollment. So also we wanted to let you know, in case you didn't know, that in our state, you can apply for coverage for a year's worth of birth control pills rather than having 12 separate 30-day refills. And the prescriptions are provided at no additional cost. You can request a smaller supply. Your doctor, your provider can also work with you to figure out what that range you would like. You are not required to pay You can get all these pills with one visit to the pharmacy without paying out of pocket. Now, I've heard some private health insurance plans aren't covering it. They're supposed to. And there's a link here where you can see the actual language. So again, if we're thinking about survivors who maybe they want a year's worth of birth control at one time, because that'll work better for them, or they want 6 months at one time, you can do that. You can help folks do that. And even if you're not a survivor, it doesn't matter. Home visitors, too, you're working with families that would like a whole year's worth supply at one time, that's possible. I hope that answers what's the status of birth control being made free of charge to women in our state. I'm referring to birth control pills. If you looked back at I'm also looking at Sarah's question on the family planning only programs. So what is covered there is lots of not prescription as well as non-prescription birth control, IUD placement and removal, and if people want it, tubal ligation, sterilization, or vasectomy. Thanks, Amber. So that's all covered again, prescription and non-prescription birth control in the family planning only program. Yes. Okay, back to EC. So guess what? Maybe you all already know this, but EC, I've been able to find EC online at Amazon by those various names that Amber brought up earlier, My Way, My Pill, for as little as $8 a pill, up to $8 to $12.50 a pill. The prices kind of fluctuate. And if you have Amazon Prime, I just try to buy as much as I can, and I get that free ship. So for our advocacy programs, you could, or home visitors, you could have some EC in your desk drawer, your back pocket. Also, you can get bulk pregnancy strips at Amazon that are a lot cheaper than even the dollar store, and I think they're better quality. So that's something we can do to help increase access. And of course, you can tell the families that you're working with if a survivor it's safe for them to be ordering EC and having it delivered to their home, they can do that too. This is the non-prescription, the one pill only. Resources, and back to you.
Thanks, Lee. I just want to share my birth control resources information that I was drawing from for my presentation. Bedsider is that site that I was showing, that I was walking you through and saying that they also have handouts that you can give out. And just to let you know, my information came from the CDC, Planned Parenthood, and the Mayo Clinic. Some questions that people had at registration that I wasn't able to go into details with, I did find links to. So that would be emergency contraception and hormone replacement therapy, birth control and breastfeeding, and emergency contraception and body weight.
Okay, so last few slides, I'm seeing our time. I think so for home visitors, it's really will be reassuring to you when you're figuring out how to support families who may be experiencing coercion abuse to know exactly what your local domestic violence program is doing right now. So if you go to our website, WS as in Sam, C as in cat, A as in apple, D as in dog, V as in victory.org, and I think Laurel could put it in the chat box for us. You can find the phone numbers and the links to the programs in your community to know how you can provide support for the families you're working with. If you need to consult with an advocate, brainstorm together, know about emergency shelter, it's really helpful to know exactly what programs are doing in our communities because they're still working with survivors every day. Next slide. We also these are a bunch of hyperlinks. We're updating our website around the coronavirus as we get new information. Then I also included some additional hyperlinks to information in Spanish and English around best practices when using our mobile devices to support survivors and advocacy, things to think about. And we just wanted to let you know that our National Domestic Violence Hotline has lots of advocates that speak other languages. I think it's over 22 languages now. So that's people that are not using the language line that are able to talk with people directly. They can also chat with folks. There's also a deaf hotline. If you go to the hotline, it'll take you to the deaf hotline. To please know that our national hotline works 24/7. It's confidential. It can connect people with anybody, any hotline or any other resources nationally. So back to Washington State as well. But it's a good thing to have on your phone, have it saved, and to know that that's a resource that anyone can call, including home visitors, including advocates, friends and family, to help get support as well. I see that, yes, thank you. We've also, again, focused on this website, which is part of the National Network to End Domestic Violence. They're updating their information around technology safety. Thought it would be useful for everyone attending this webinar to see what they're, as we hear more from advocates out there in the field about like how they're connecting with survivors and what they can do to best support folks who are experiencing coercion and abuse. This might be good information for you all to just check in with every now and then. Okay, that was a lot of information. We hope you all feel like you know more about things to ask when it comes to birth control access and a little bit about healthcare coverage in Washington State for survivors and minors. And we just want to thank you for all the work that you're doing every day. We know you are the people that survivors and the families that you're working with are turning to as another trusted person in their network, in their circle, and that your relationship is really the intervention and helping folks. So there is information in Spanish about all the forms of birth control, including emergency contraception, on the bedsider.org website. And yes, I hope that answered that question. And then I saw there was a question about EC on hand. Could someone help me with that, what that question was?
Yeah, the question was from Joseph. What is the best way for our DV agency to apply to have access to emergency contraception available on hand for survivor participants?
Go to Amazon and order it, Joseph. Budget $100. I mean, you can buy 10 pills and have it on hand. And then what we've been encouraging programs to do is just have it available so that nobody has to ask you for it. So right now, knowing that you're working more remotely, if you're still having people in your shelter, if you have private space or you're having fewer families, we just say like have it available in the bathroom with some information about it. And I think that's going to be one of the handouts included for people attending the webinar, some general guidelines around taking EC, have that available. If you're meeting with people, if you're just meeting with people remotely, just giving them information about it and telling them that you don't need a prescription for the one-step pill, that maybe a friend or a family member could order it online if they can't order it directly, and then get access to that pill. But we've just been encouraging people to like budget for it and then have it available for people so that they don't have to ask for it, so they can be treated with dignity with some information about it. And people will people have just been kind of taking what they need. Programs have to figure out how much to have out at one time, but just making it something that's easy to access. I hope that answered that question. Every once in a while I get a grant to buy a whole bunch of it and I send it out, but I haven't had a grant for that in a while.
Britta offered that they believe there are grants out there that can help programs get EC, pregnancy tests, and condoms. And then Elena had a question specifically relating to accessing birth control currently in regards to COVID. Some clients have had difficulties getting into PP wellness visits in person with providers. Do you have specific resources we can point clients to access birth control during this time?
I don't right now, but Elena, I think that's a great question. We'll do our homework and see if we can see if there's anything out there. We'll definitely send it to everybody who signed up for this webinar, and then we'll make that information available on our website in our COVID roundup. So thank you. Britta, I think what you're referring to is this if this is Britta from Spokane, those were grants that I was able to get for on behalf of WSCADV to buy emergency contraception and pregnancy tests. I don't have that right now. So that's why I'm really referring people to the cheapest place I've been able to find it. So we don't know specific grants right now for EC. That was WSCADV. But yeah, so we'll do our homework and then yeah, go for the online for the cheapest version right now. So if we get information about where we can access birth control cheaply, if not free, we'll put it up here and we'll send it to everyone as well. Anything else, Amber, you would like to say?
No, just thank you and reach out if you have questions.
Thanks, everyone. We are so appreciative of you.